Hello guys, welcome to the AIIMS series. Just before the Central Institute examinations, we are trying to go through the previous year AIIMS paper so that you are not having any doubt regarding the correct answer, and you can also come up with the good discussion on that important topic about which a question has been asked previously. So let's get started. The question number 1. This is your recall series of 2017. Identify the refractive error. So look at the image here. They have given you the focus of the rays, okay, and this is your retina. The focus is taking place in front of the retina. So focus is taking place in front of the retina, therefore very clear cut. What is this? This is actually the myopia. If this focus would have been going posterior to the retina, the answer would have been the hypermetropia. So now look at the options: A, myopia; B, presbyopia; C, hypermetropia; and D, astigmatism. So answer to this question will be myopia. There is no astigmatism because you are getting a point focus. The rays are coming to a point focus. In cases of astigmatism, the rays won't come to a point focus, rather they will form the focal lines, and these focal lines are called as terms conoid. So therefore this is not astigmatism. Now you have two things, one is myopia and another is hypermetropia. In the hypermetropia, it will go behind the retina, while in the myopia it will be focused in front of the retina. Why not presbyopia? Because presbyopia is not a refractive error. Very important thing, the presbyopia is not a refractive error. It is just a physiological insufficiency which is taking place due to the aging of the lens and the ciliary muscle. Alright. Next question, following picture exhibit which cranial nerve palsy? So see the three pictures that they have tried to given you, okay. Now if you see the second image, when the patient is seeing in this gaze, okay, so this eye is adducting, but there is no abduction. There is no abduction in this eye. When the patient is looking in the left gaze, the right eye will adduct and the left eye had to abduct. There is no abduction, which shows a deficit in the lateral rectus. Now if you see the other picture, now when the patient is trying to see in the right gaze, okay, this was your left gaze and this is your right gaze. When the person is trying to see in the right gaze, now the right eye is abducting. So there is normal abduction and it is also showing adduction. So there is normal adduction also. That means the only problem that the person is facing is looking laterally in the left eye. So that means there is a left lateral rectus palsy. There is a left lateral rectus palsy. Now try to look at the options. They are asking you the cranial nerve palsy. Lateral rectus is supplied by the sixth nerve. Always remember, all by the third nerve, SO4 and LR6. So all of the extraocular muscles are supplied by the third cranial nerve except for SO4 and LR6. Here we are talking about the lateral rectus, so we are concerned with the sixth nerve. So your options are oculomotor nerve, then we have abducent nerve, trochlear nerve or facial nerve. Now facial nerve is a motor nerve, right? Trochlear nerve, that is fourth nerve, supplies the superior oblique knot. Abducent nerve is the sixth nerve, that is supplying the lateral rectus, and oculomotor nerve is the third nerve. So answer to this question is the B, abducent nerve. Alright. Next question, what is the most common epithelial lacrimal gland tumor? Your options are adenoid cystic carcinoma, pleomorphic adenoma, mucoepidermoid carcinoma, and malignant mixed tumor. Now when it comes to the tumor of the lacrimal gland, you have to always remember one thing, that the most common benign, The most common benign is the pleomorphic adenoma, right? While the most common malignant is the adenoid cystic carcinoma. Adenoid cystic carcinoma. Now, which one is more common, whether it is benign or malignant? Obviously, benign tumors are more common than the malignant tumors. So, you have both of them in the options. We have pleomorphic adenoma also, we have adenoid cystic carcinoma also, right? So, which one should be preferred? Because they have not specified whether they are asking you most common benign or whether they are asking you most common malignant. So, you have to go with the most common altogether, and that is the benign tumor. Therefore, answer to this question is the pleomorphic adenoma. Had this question been what is the most common malignant epithelial lacrimal gland tumor, then obviously your answer will become the adenoid cystic carcinoma. Okay. Next question, a patient of glaucoma presents with the bulging of the cornea. The most likely diagnosis is, your options are keratoconus, keratomalacia, staphyloma or granular dystrophy. This we had actually discussed in the AIIMS series 2018 also. The answer to this question is the staphyloma. In the keratoconus, we have got just the conical protrusion. We have the conical protrusion of the cornea, right? So, there will be no glaucoma. We have the bulging in the form of a cone, but there is no glaucoma. Keratomalacia is due to the vitamin A deficiency. There you get the corneal ulcer. Again, there will be no glaucoma. Here we have the corneal ulcer due to the cirrhosis. You have conjunctival cirrhosis, corneal cirrhosis, bitoid spots, and there is no glaucoma here. Now, if you see the D option, granular dystrophy, it is actually the corneal dystrophy. In cases of the corneal dystrophy, especially if they are present in the endothelium, there will be corneal edema, right? And this corneal edema will lead to the haziness, and there will be again no raised intraocular pressure, no glaucoma. So, answer is staphyloma. This is occurring whenever you have the perforation. Whenever we have the perforation of the large corneal ulcers, that is usually taking place in the cases of the bacterial keratitis. When there is a large corneal ulcer and it has perforated, so whole of that slough will be coming out. We have inflammatory cells, pus cells, exudates, and then the fibrotic tissue. So, this whole of the fibrotic tissue along with the inflammatory cells is bulging out, and this is happening due to the raised intraocular pressure. When there is lot of inflammation, these inflammatory cells will be blocking the trabecular meshwork, they will be raised intraocular pressure, and this raised intraocular pressure will push all of these things anteriorly, and that will give you the anterior staphyloma, right? Next question, a 60-year-old diabetic male presents with the decreased vision. Fluorescein angiography is shown in the picture. What is the most likely diagnosis? Now, try to see this FFA. This is actually a FFA picture. What you are able to see? Can you see these small bulb like areas, small dots? So, what are these dots? These are the microaneurysms. These are the microaneurysms, and you know microaneurysms are typical of the diabetic retinopathy. They are the hallmark of diabetic retinopathy. Now, your question is whether it is NPDR or whether it is PDR. So, look at this, there is pooling of the blood. There is pooling of the blood or the leaking of the blood, we have the collection of the blood. So, that means there is a hemorrhage, and this hemorrhage will be occurring due to the neovascularization. So, this is very typical of the neovascularization, and neovascularization is found in the PDR. Neovascularization is found in the PDR. Therefore, now look at the options. We have mild NPDR, mild non-proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy, butt-short choroidopathy, or proliferative diabetic retinopathy. So, it is not the NPDR. It's not NPDR, not NPDR, rather it is not a choroidopathy also. So, what is the answer? Answer to this question is the proliferative diabetic retinopathy, where you have lot of neovascularization. Due to neovascularization, there will be bleeding, there will be leaking, there will be pooling of the blood, and that is shown in the form of this FFA. Next question, a patient is presenting with the endophthalmitis which is occurring after 5 days of the cataract surgery. All of the following treatment regimens can be followed except. So, what they are saying that when you are having a patient is presenting with the endophthalmitis, how should you start? The options are intravitreal injection, intravenous steroids, pars plana vitrectomy, and topical antibiotics. So, all of the following should be taken except you have to see that what should not be started with. So, whenever this patient is coming with the endophthalmitis, okay, whenever the patient is coming with the endophthalmitis, you have to first assess the visual acuity of this patient, and if the visual acuity is more than or equal to hand movement, if the visual acuity is at least hand movement or better, then we start up with the antibiotics. And these antibiotics are given by all the routes. So, whether it is topical, systemic, intravenous, intravitreal, though the most important is the intravitreal antibiotics, but we give all. Then after 24 to 48 hours of controlling the infection, we also start up with the steroids. Now, there is always a controversy about these steroids because some people say that steroids should not be given in the cases of infection, but in most of the cases we do give these steroids after controlling the infection because there is a whole lot of inflammation. So, steroids are also required. Okay. Now, if this patient is having the PL positive, okay, or less, if the visual acuity is very less, PL positive, then we go for the pars plana vitrectomy, or if there is no improvement after this. If there is no improvement after giving this antibiotics, then also we do this pars plana vitrectomy, and then finally if you are not getting anything, then we do the evisceration. So, if you look at the options here, what is not followed? We have to give the intravitreal injection, you have to give the intravenous steroids, and you have to give the topical antibiotics. So, what is not followed immediately is the pars plana vitrectomy. Alright. Next question, identify the given condition. What is this? Can you see a growth? This is a growth coming from the conjunctiva and it is growing over the cornea. So, what is this? Is it a pingicula? No, it is not a pingicula. Pingicula is just the yellowish discoloration. It is just the yellowish discoloration that you are getting, right? Pterygium, chemical burn. In the chemical burn, we get the symbliphron. Symbliphron means that there will be adhesion of the palpebral conjunctiva and the bulbar conjunctiva. This is not a symbliphron. In the thermal burns, whether it is a thermal burn or it's a chemical burn, because of the raw surfaces, we have adhesion of both of the conjunctiva, that is called as a symbliphron. So, actually it is a pterygium, which is a growth of conjunctiva growing over the cornea, and you have got different parts of this, like we have got, this is the apex part, then we have got the neck, this is the body, and then we have got the tail. So, apex is always towards the cornea. Can you see this? The apex is always towards the cornea. So, whenever it is growing, it will be growing over the cornea. Slowly and gradually, it is pressing the cornea. It will be causing astigmatism. Very important thing, that it causes the astigmatism. This is the most important way why it is causing the diminution of vision, and the type is with the rule astigmatism. Then slowly and gradually it is crossing the pupil also, and then it is causing the obscuration of the visual axis also. Next question, identify the test shown. A. Tonometry, B. Laser interferometry, pachymetry or refractometer. Can you see this? This is actually a probe which is going on, and this probe is of the Goldmann's applanation tonometer. It is a probe of Goldmann's applanation tonometer, and I always tell you that there was a time for so many years that AIIMS people were very fond of asking about the tonometers, tonometry, image based questions, the principles. So there was a period. Now, so this is one of the favorite topics. This probe is of the Goldmann's applanation, Goldmann's applanation tonometer. Okay, applanation means that this is a kind of flattening. Here we have a tonometer which is causing the flattening of the cornea, right? And you should also know what is its principle. Read everything about the Goldmann's applanation tonometer. It's a very important topic. It has the Imbert-Fick law. Imbert-Fick law, which says that the pressure is equal to force upon the area, and area is fixed here. So, it is a variable force tonometer. Area is 3.06 mm diameter of the cornea. This is a fixed area tonometer, and this probe that you can see here, it consists of the biprism. It consists of the biprism, due to which you are able to see the splitted circle. So, half of the circle like this and half of the circle like this, these are called as the Myers. So, when the Myers are just touching each other, that is the end point, and you have to take the reading at that point. Next question, a 60-year-old male, they have not given old patient, you can take a 60-year-old patient with a cataract surgery post 1 year. So, a 60-year male has come up after 1 year of the cataract surgery, and again he is complaining of diminution of vision, and they have also given you the image. What is the diagnosis? Now, when they are talking about the cataract surgery 1 year back, that means they are talking about the late post-op complication. They are talking about the late post-operative complication of the cataract surgery, and the most common there is the after cataract, also called as the secondary cataract, that can also present with the diminution of vision. Now, if you look at this image, what can you see here? We can see these small vacuoles here. So, that means it is a case of PCO, that is after cataract, where you can see the vacuolated cells. So, which kind of after cataract can show the vacuolated cells? That means it is the Elshing's pearl cataract. Therefore, it is a kind of the Elshing's pearl cataract, though the more common is the Somering's ring cataract, but here what they have shown is the Elshing's pearl cataract. So, see the options now. The first is Irwin-Gass syndrome. Irwin-Gass syndrome is the cystoid macular edema in the pseudophakia, that is also presenting as a late post-operative complication, but you will not get this. The cystoid macular edema, they will be giving the OCT finding, or they will be giving the FFA finding. Then the B is after cataract. So, this is the right option. It is the Elshing's pearl kind of after cataract. Then third is the UGH syndrome. UGH syndrome, it is actually uveitis, glaucoma and the hyphema, uveitis, glaucoma and the hyphema syndrome, and usually it occurs due to the ACIOL. When we give the ACIOLs, due to the release of the inflammatory cells, there can be uveitis. Uveitis can lead to the trabecular blockade, and that can lead to glaucoma. It also leads to the hyphema, that is blood in the anterior chamber, while D is the endophthalmitis. Now, if the patient is having endophthalmitis, there should be, pain, there should be redness, then there should be diminution of vision. So, picture will be entirely different. Okay, so this is not a case of endophthalmitis. Therefore, answer to this question will be after cataract. Next question, silent choroid on FFA is a feature of. A option, Best disease. Next, age-related macular degeneration. C, Stargardt disease, or D, cystoid macular edema. So answer to this question is the Stargardt disease. This is again a direct question. In the Stargardt disease, we get the silent choroid, or it is also called as the dark choroid. Silent choroid or the dark choroid. Stargardt disease is actually the macular dystrophy. It is a macular dystrophy where actually you are getting the accumulation of the lipofuscin. Accumulation of this lipofuscin over the macula. So it is covering whole lot of choroidal fluorescence, and due to which the person is giving you just the silent choroid or the dark choroid. Now, in cases of the Best disease, this is also a macular dystrophy. It is also a macular dystrophy, but this is giving you the egg yolk appearance. This is giving you the typical egg yolk appearance and not the silent choroid, because here you have the localized deposition. Here also we get the deposition of the lipofuscin, but it is just the localized deposition, not the diffuse one. So answer is not Best disease. Age-related macular degeneration. Age-related macular degeneration, that is responsible for the drusen's, or it is responsible for choroidal neovascular membrane, PED, and not the silent choroid. Rather, you will be having more of choroidal activity, especially in cases of wet ARMD, because wet ARMD means choroidal neovascularization. If I talk about the cystoid macular edema, then this typically gives us the flower petal appearance. This typically gives the flower petal appearance on the FFA. So answer to this question is the Stargardt disease. Next question, identify the finding below. What can you see? So there is clear-cut ptosis which is present here. This is the right eye of the patient and this is the left eye of the patient. Now look at the options. First is the ptosis of the right eye. This seems to be right. Entropion of the right eye. So this is wrong. Entropion is the inward turning. It is the inward turning of the eyelid. So you cannot see the inward turning of the eyelid here, rather you are seeing the drooping of the eyelid, that is a ptosis. Legophthalmos of the right eye, so it's wrong. Ectropion of the left eye. So this is also a wrong option. Ectropion means the outward turning of the lid margin. So you are not seeing any deformity in case of the turning. There is neither the inward turning nor the outward turning. The only problem that you can see is the drooping of the right lid, that is the ptosis. Next question, the visual pathway defect. The visual pathway defect at the level of optic chiasma will cause. So how to solve this question? When the person is having a problem with the optic chiasma, that means the nasal fibers are affected on both sides. Nasal fibers are affected on both sides, and you know that the field is always diagonally opposite. So when the nasal fibers are affected on both the sides, therefore temporal field will be affected. Temporal visual field will be affected on both the sides. So this will be called as bitemporal. If this is the visual field of this patient, right, this is nasal and these are the temporal. So this patient will have the defect that will be present on the temporal side of both the eyes. So this will be called as the bitemporal hemianopia. Look at the option: binasal hemianopia, bitemporal hemianopia, central scotoma, or the bilateral hemianopia. So answer to this question will be bitemporal hemianopia, because the problem is occurring in the nasal fibers of both the sides. So this was about the AIIMS recall questions 2017. Hope you had a clear idea. You also get a glimpse of what are the important topics and the favorite topics of the AIIMS people, because you know every institute examiners have a particular choice, particular preponderance of the topics that they are asking, and we always have some confusion regarding the correct answer. So go through these questions, try to prepare all these topics in whole. Okay, the exact questions will not be repeated, but topics are always repeated. See, if there is any query, you can always ping me up on any of the social media platforms. You can follow me on Insta, and you can be a part of our huge family on the Facebook group and the Telegram group. Do prepare these questions and also be a part of our daily quiz at 10:30 p.m. on our Telegram group, so that you have the finest of preparation before the final exam. Thank you and happy ophthalmology.